everyone, my name is Natalia. I'm one of the PGY1s. My small talk is on first trimester bleeding. I kind of gave it away, but special thanks to the small talks team. So Doctors Delgado, Pandia, and Rayber for their help with this presentation. So as with every small talk, we'll start with the case. We have a 28-year-old female. She is G3 P1011 with no other past medical history. She's coming in for vaginal bleeding and abdominal pain. What are some things that you guys would want to know about the HPI? LMP, yep. Anything else? Review of systems. That's okay. All right, so HPI. So you find out that she had a positive home pregnancy test last week. She has not yet established prenatal care, but she has an appointment next week with her OBGYN. Her LMP is March 7th, and her menstrual periods are fairly regular, so this puts her at 7 weeks and 3 days by LMP. She first started noticing a little bit of vaginal spotting yesterday, and it's gotten a little bit heavier today. She's used 2 pads this morning. She's also endorsing some cramping suprapubic abdominal pain. On review of symptoms, she denies any other infectious symptoms, no fevers, no abnormal discharge, and no urinary symptoms. On exam, her vitals are all within normal limits. She's in no acute distress. Cardiopulmonary exam is unremarkable. Her abdomen is soft with some mild tenderness to palpation in the suprapubic region, no rebound or guarding, no CVA tenderness. GU exam is mostly remarkable for a little bit of vaginal bleeding in the vaginal vault. The cervical os is closed, no CMT, no annexal fullness, masses, or tenderness. So with that being said, here's our outline for the small talk today. We're going to go over the differential diagnosis, workup of these patients, management, case wrap up, and then we'll go over some key points. So differential, can someone give me a differential for first trimester bleeding? Okay, good. Subchorionic hemorrhage. Yes, spontaneous abortion. Heterotopic, okay, so those are some. So here's our list. So spontaneous abortion, obviously the most common cause. Ectopic pregnancy is the big one we don't want to miss. Implantation hemorrhage and subchorionic hemorrhage. And then always there's non-pregnancy related causes of bleeding, such as trauma, tumors, warts, polyps, fibroids, and vaginitis. We are not going to be really covering these today. Remember also, if the patient's presenting with abdominal pain in addition to the bleeding, to always consider non-OBGYN causes of abdominal pain. So first things first, spontaneous abortion. I'm sure you've all seen this infographic or some version of it. Threatened abortion is going to be the most common presentation, and really the way to think about this is that it's a normal pregnancy with some bleeding. So you have a fetal heart rate, you have an IUP, the cervix is closed, you're just having a little bit of vaginal bleeding. The other way I like to think about it is that the eyes are the ones that have an open cervix. So inevitable and incomplete abortion are going to have an open cervix, and then complete and missed are the ones that do not have fetal cardiac activity. Ectopic pregnancy, Young is going to go over this in his next presentation, but just briefly, just remember that all pregnant patients have an ectopic until proven otherwise. And most of these patients will present with abdominal pain. They may have a little bit of vaginal bleeding, but due to the nature of the location of the ectopic pregnancy, usually the bleeding most of the time is more mild than like in a spontaneous abortion. Heterotopic pregnancy. So this is where you have an IUP and an ectopic pregnancy. It is very rare. However, there is an increased risk if the patient conceived via IVF or any other kind of assisted reproductive technology. Then we have implantation hemorrhage. This is a physiologic cause of bleeding, and it occurs around 10 to 14 days after fertilization, around the time of the missed menstrual period. And it's thought to be related to implantation of the fertilized egg in the decidua, usually very mild. Subchorionic hemorrhage. So what this is it's a hemorrhage bleeding in between the gestational sac and the uterus, or between the placenta and the uterus. The typical presentation of this is usually painless vaginal bleeding, but you can have some mild abdominal cramping. Causes vary, but some causes are trauma, hypertension, history of pelvic infections, recurrent miscarriages, malformation of the uterus, and IVF. With this, you have an increased risk of spontaneous abortion and placental abruption. The increased risk of placental abruption is 5 times. and also increased risk of gestational hypertension. Management of these patients is usually expectant. So if the mother is stable, the fetus is stable, and there's no signs of large volume blood loss, usually you can do conservative management with close outpatient follow-up for repeat ultrasound. But I think for the most part, we probably get our OB/GYN colleagues involved so we could facilitate that close outpatient follow-up. So workup for your first trimester bleeding patients. So initial approach, obviously this is about first trimester bleeding, but if you have an early pregnancy and the patient also complains about abdominal pain, like I said before, assume ectopic pregnancy until proven otherwise. So astutely, as we've all been taught, we will do a fast exam to look for any free fluid. And then you start getting your blood work, your UA, you obtain your history and physical and pelvic exam, and then you want to proceed to do a transabdominal pelvic ultrasound. So remember that a transabdominal ultrasound is better, the uterus is best visualized with a full bladder. This is as opposed to the transvaginal ultrasound where you want an empty bladder. You must see the yolk sac in order to confirm an IUP. The fetal heart rate is anywhere between 120 and 160. And usually the fetal heart rate you should be able to measure it or at least visualize it when the fetal pole is 5 millimeters. And that's usually around 6 weeks gestation, but everybody varies widely, especially if the patient's menstrual period varies per month. So also the transabdominal ultrasound must be performed with an attending if you're confirming the IUP. This is kind of out of the scope of emergency. It's not really necessary in the emergency department, but if you do want to, if you're seeing a fetal pole and you want to confirm gestational age, remember that in the first trimester, the crown rump length is what is most accurate to confirm gestational age. When you're doing the transabdominal ultrasound or any kind of ultrasound, remember the 10-25 rule. So when the gestational sac is 10 millimeters, you should be able to visualize a yolk sac. When it is 20 millimeters, you should be able to visualize a fetal pole. And then when the fetal pole is 5 millimeters, like I said before, you should be able to visualize cardiac motion. I'm sure everyone's seen this before, but this is just a trend of the HCG throughout pregnancy. So in the first trimester, especially early in the pregnancy, the HCG should double every 48 hours. And the most important number here is 1500. That's usually the discriminatory zone that we use here and most people use for when you should be able to see and diagnose an IUP on transvaginal ultrasound. However, again, everybody varies very greatly, and the absence of an IUP on transvaginal when the HCG is greater than the discriminatory zone is not absolute proof of an ectopic pregnancy, or because there's, like I said, people vary, and also it could be a very early multiple gestation, so like a twin pregnancy. So management. So remember the code 54 if you're at Kings County which is in place for obstetric emergencies. So there's multiple indications for code 54s for various OB/GYN complaints, but in regards to first trimester bleeding, you would call a level 1 for hemodynamic instability or severe hemorrhage, and a level 2 for a stable patient with a positive FAST. So ROGAM. So this is a slightly controversial topic due to the lack of good evidence. Unfortunately, pregnant patients, since they're a vulnerable population, it's not ethical to really do a lot of studies on these patients. So there's really not great evidence. But the purpose of this is ROGAM is an anti-D immunoglobulin, and the goal of administering it is to prevent maternal sensitization and hemolytic disease of the fetus and newborn in subsequent pregnancies. There's really few downsides to administering ROGAM. So the only really big ones are the cost, and even then it's not terribly expensive, but that's the cost of doing the type and screen and administering the medication itself, the time it takes for the patient to be in the emergency room or wherever they're getting administered ROGAM, and then the risk of adverse reactions is extremely low. However, so this is the ACEP and ACOG guidelines. So ACEP is actually a little bit more liberal in administering ROGAM. So their recommendation is for anybody with first trimester bleeding. It's a level B, so a little bit weaker, but they recommend treatment with ROGAM. And you can consider in patients with minor trauma. ACOG, however, they're saying treatment in patients with an ectopic in the first trimester. And then you can also consider level C for patients with threatened abortion, but with significant bleeding, or if they receive instrumentation. So the dose is 50 micrograms in the first trimester, and it seems to be, you've probably all seen that attendings all vary, but since ASAP recommends it and it's our OBGYN department's practice to give it, I think most attendings will tend to administer Rogaine. Yes. See, we have some disagreement.
I think I just feel the lack of data. I think a lot of great data saying really help another 12 weeks because England, which has a unified health service, has not had one documented case of fetal eye drops in the decades that they stopped giving Rogaine after 12 weeks. And it's not like they do like polysystems things and they just don't pay for it, so they don't give it and they don't have any fetal eye drops. I think that's pretty good data.
Yeah.
Nobody's experimenting. They just stop giving it.
So Dr. Schechter said for anybody on Zoom, so in England, where there's universal health care, they stopped giving Rogaine because there was not really any good data and they haven't had a single case of hydrops fatalis. So pretty good indication to not administer Rogaine. So under 12 weeks. Got it. So here's kind of a little flow chart that I put together for how to manage these patients. So obviously if anybody's hemodynamically unstable or if you have a positive FAST, you're going to be calling OBGYN and a code 54 immediately. Otherwise, you'll go through your workup of doing a pelvic exam, blood work, and then a transabdominal versus transvaginal ultrasound. If obviously if you see an ectopic, you're also going to consult OBGYN for pharmacologic versus surgical management, which has been covered in previous lectures. And then if an ectopic cannot be ruled out, you'll frequently ask these patients, or if there's a threatened abortion, you want them to have close follow-up for repeat HCG and repeat transabdominal ultrasound. So I wanted to talk briefly about some counseling for these patients. So I think we see these patients very frequently, but for most of these patients, this is a very traumatic experience and it's a very traumatic diagnosis, especially, I like to always ask pretty upfront if the patient, if this is a desired pregnancy or not. So to kind of guide the rest of the encounter, but it can be a very traumatic experience for patients. So always be kind and sensitive. Do not use the word abortion, and also just be sensitive in any patient that you're doing a pelvic exam, try to be sensitive. I know in medical school, they taught us to never tell a woman to spread open her legs because that can trigger some emotions if they've ever had any kind of sexual trauma. And then also just some statistics to share with patients if you diagnose them with a spontaneous abortion or threatened miscarriage, is that even though it's not really talked about in our community, unfortunately, very, very often, it is a fairly common diagnosis and thing to go through. So it's estimated that about 15% of pregnant women will experience a miscarriage, although those estimates actually may be higher because there may be women who experience a miscarriage, but they think that it's just their menstrual period. But out of those 15% of pregnant women who have experienced a miscarriage, only 2% of women have experienced 2 consecutive losses, and only 0.4% experience 3 or more consecutive losses. So I think that's a nice tidbit of information to share with your patients. Also, at 7 to 11 weeks, if there is fetal cardiac activity, but vaginal bleeding, actually 90 to 96% of those patients will go on to have a viable pregnancy and do not miscarry. Also, chromosomal abnormalities account for about 50% of spontaneous abortions. And so it's good to counsel your patients that most of the time it's nothing that they did and they couldn't have avoided this. Also, just remember, if you're having patients that are coming in for recurrent pregnancy losses, obviously for most of these patients, you're gonna tell them to follow up with their OBGYN, but it's important that you really stress that fact and that they may need some kind of fertility counseling in the future if they want to have a viable pregnancy. So just a case wrap up. So our patient had a positive UPreg. Her HCG was 2300, RH negative, and a hemoglobin of 12.7. UA was negative for any kind of acute cystitis. Transabdominal ultrasound was performed. She has a gestational sac, but no IUP and a negative FAST. Transvaginal ultrasound is ordered and performed, and it kind of confirms those findings. And no other mass is identified. So no ectopic. So this is a pregnancy of undetermined location. So you choose whether or not you want to give Rogaine. The patient is discharged home with very strict return precautions and told to return in 48 hours for repeat HCG. Now, of course, if the patient is unstable, then that is a different story. That is an ectopic and the OBGYN needs to be consulted. They come back 48 hours later, their HCG has doubled appropriately. Repeat transvaginal ultrasound reveals little aliens, because that's what I feel like babies are sometimes. But you get a gestational sac with a yolk sac. So you confirm an IUP. They had a threatened abortion, and you counsel them appropriately. So summary and key points. Assume all women of childbearing age are pregnant until proven otherwise. Assume all pregnant women have an ectopic until proven otherwise. HCG over greater than 1500 is a discriminatory zone. That's what's used in most standardized board exams and should be visualized on transvaginal ultrasound. The evidence of ROGAM is limited. ASAP recommends giving it, but of course, very controversial, but it sounds like not so limited with the UK studies. Consider non-pregnancy related causes of bleeding as well. These are my references. Any questions?
Just in terms of the discriminatory zone,